Hey, this is Allison again. This is another video in my little grouping of theory and equipment lectures for neonatal ventilation. That we're going to cover high frequency oscillatory, high frequency jet. This one is about conventional, and the last one will be non-invasive. So we're going to talk about neonatal conventional ventilation. And this lecture will be specifically for respiratory students, new respiratory therapists in NICU, and newborn ICU nurses that want to learn more about the respiratory equipment that their baby is on. Come on. There we go. Okay, so the lecture outline. Things we're going to discuss during this lecture are the modes of ventilation, which will probably be a little bit more of the heavy part of this video. So we're going to discuss assist control, Simv, pressure support ventilation, and pressure regulated volume control, which is kind of a variation of an assist control or Simv, but it's growing in popularity both in the neonatal and adult patient populations. It's a great form of ventilation. It is very lung protective and also very comfortable for a patient. So then we're going to discuss settings and ranges, pathologies and indications, equipment management, and airway securing and management. Okay. Neonatal and conventional ventilation. So this is a form of invasive positive pressure ventilation that supports and controls ventilation in a similar pattern as normal physiologic breathing. So essentially it's just souped up normal ventilation, how we would breathe. So normally how we breathe, we take a breath and we have our own spontaneous respiratory rate, our own tidal volume, our own minute volume, but this is controlled and we can alter and adjust it as we need. So for this to occur, we need an invasive artificial airway. It's necessary for delivery and properly sized. There are different modes and strategies that you can incorporate. There is also different ways and modes we can deliver this. So we can give full support, intermittent support, and spontaneous ventilation to strategize what we're working on, what our indications are, and what we're aiming for our end goal. So jumping straight into modes, we're going to discuss assist control. This is a full control mode of ventilation. So that means when I teach adult mechanical ventilation, I like to call assist control. I like you as the therapist are driving the car. So think of it as when you got your driver's license. Your patient is trying to earn their driver's license, which is extubation. In assist control, you're driving the car. Your settings are the ones in control. This is not a common mode of ventilation used in the neonatal population, and that's because of just the different breathing pattern from neonates to adults, but some NICUs will use assist control. It is a very common mode of ventilation used in the adult world. We can deliver this with either pressure control or volume control, whichever is best indicated for the situation. Like I would use a pressure control if maybe I was worried about excessive barotrauma, or if I have a massive leak. Sometimes I'll set it in pressure control because the volume control won't reach the volumes if maybe I have too small a tube or something like that. So the difference between volume and pressure control, so with a set tidal volume, the set tidal volume is consistent. The peak pressures are variable and flipped. In pressure control, the peak pressures are consistent and each individual tidal volume has variability. So, and this happens, so the set tidal volume, whether that be a pip or a volume, what this last bullet is saying, so we could be either in pressure control delivering a pip or volume control and delivering a set volume. That set volume, tidal volume, whatever it be, will be the same if both it is machine delivered and triggered, or if it is patient triggered. So whether it be the set rate, let's say we have a set rate of 20, all 20 of those breaths will have the same tidal volume. If a patient triggers and breathes above that set rate of 20, that will also be the same tidal volume. You can see it in this little diagram. Again, sorry for my pictures. Down here we have our PEEP. Up here we have our either set tidal volume and volume control, or PIP and pressure control. For a machine-delivered breath, we just start directly at our PEEP. We go up, reach our set tidal volume or PIP, and then come back down to exhalation. Let's say your patient wants a breath. The patient can trigger the breath. So this is the drop of that diaphragm, that negative force that comes from the drop of the diaphragm. And then we go on up to our set tidal volume or PIP, and then come down to exhalation. That is assist control. This is would be if you have a patient that is completely apneic, potentially paralyzed. We don't really use paralytics in newborns, but this is a full control ventilation. Synchronized intermittent mechanical ventilation. This is the mode that I most prefer for neonates. It is considered a hybrid mode of ventilation. It combines both control ventilation and spontaneous ventilation into one. I like to think of it as the little love child between control and spontaneous. Oh, the little love baby. So we can provide SIMV in both either a volume or a pressure control just for your control breaths, just as you would in assist control. So you will be both delivering mechanical breaths and also supporting spontaneous breaths with pressure support. So your machine delivered breaths, you have your set tidal volume delivery. So whatever your rate is, it will deliver your set tidal volume. In between, if your baby wants to take a breath, a little spontaneous breath in between these set the set rate, they will be supported with pressure support. So it's a combination. The synchronized comes in when, let's say, the machine is registering, okay, I'm about ready to give a control breath. It's time to give that control breath. But then your patient, around the same time, triggers a breath. It will synchronize with that patient and deliver a mechanical breath when your patient triggers. That's what the synchronized means. So here's SIMV. I'm going a little fast in these modes just because they're pretty similar to adult modes of conventional ventilation. So you RT students should know this by now. So again, here's another diagram showing SIMV. We have our PEEP down here, and then we have our set tidal volume or PIP up here. This would be a machine delivered breath right here. So we start at our PEEP, our baseline, and we deliver that positive pressure breath, come down to exhalation. This would be a spontaneous breath taken between our set rate. There we have our negative deflection, and then our pressure supported breath. Again, my favorite analogy to explain pressure support is like in cars, when at the end, the big race, when the one car gets crashed and is broken, and then Lightning McQueen pushes him across the finish line so that they can have their moment together, because life is more than just racing. Yes, I've seen this movie a couple times. And they call it, oh, he's just giving him a little bump draft. That's what you're doing. You're just helping support to get to the volumes you want. A little smack on the ass to get those spontaneous breaths up to where they need to be. It is common for these spontaneous breaths to not be quite as large as your set. That is a semi-common practice, but they'll be close. It might just be slightly smaller than a mechanical breath. Okay, so now your patient triggers another breath, and it's about time for another machine breath to be delivered. That negative deflection of the diaphragm, and the ventilator just goes, oh, I see you want a breath. You know what? I see you want it. We'll just do the whole thing right now. That is Simv. Pressure support or spontaneous ventilation. This is a spontaneous mode of ventilation, so the baby has to have their own respiratory rate. If we're giving tons of sedation for whatever reason, or maybe they're just kind of weak, maybe they're still growing, they have dealing with immaturity, might not be the best. But say you have a big kid that maybe goes to surgery and is a post-op, or is a cooling kid, or an airway kid, a baby that's intubated for an airway issue. This is a great mode. It's also considered a weaning mode of ventilation. One thing that is a little bit different is you can both provide spontaneous breaths with either pressure and a volume support, but lately they've been moving towards a volume support of ventilation, which is the same. On those spontaneous breaths, you use an additional pressure to help support those breaths up to the volumes we want. With volume support, we use an additional set volume to support those breaths to where we want them to be. And that's how kind of the little bit difference with neonatal pressure support ventilation compared to adult. Most commonly, we'll have a set volume, mils per kilogram, that we will set, and it will help reach those volumes. Ideal for ventilator weaning and assessing for extubation. We can totally see how the baby is breathing on their own, what volumes they're getting, making sure that their rate is appropriate. It's great to just see how they'll breathe off the vent. And it's comfortable for spontaneously breathing patients while still providing adequate ventilation. So again, that little tap on the little booty to help get those volumes where we want them to be. So here's PEEP, and then inhalation. See, we can go up and we're supporting their own spontaneous effort. So every single one of these breaths is spontaneously triggered, and then we either use that set pressure or that set volume to allow for inhalation. And you will see a little bit of variability in their volumes, but that's just because normal humans don't have I don't consistently have a 350 tidal volume every single breath. I'm human. I'm going to have some variability in my own spontaneous volumes. As long as they're in a similar range of one another, it's okay to have a little bit of variability because they're little baby humans. They are going to have some variability just like any other human. Pressure regulated volume control. You'll hear it called PRVC. In the adult world, you might hear it called VC+, literally with a plus sign. In the neonatal world, you'll hear it called volume guarantee. So this is what, if we have volume guarantee set on a neonatal ventilator, this is what it is. Same theory. That's why I'm covering just the theory. So it is it's another love child. It's a little love child between volume and pressure control ventilation. And what it is we have a set volume. So we have our set tidal volume in a volume mode. But we control and limit our peak pressures so that the baby can't cause excessive barotrauma to their lungs. A lot of times on the ventilator, you'll see it called a Pmax. Another thing is, with normal conventional ventilation, you set flow with volume and I time with pressure. In PRVC, we set an I time with volume and the patient can control their own flow, and that is what makes it comfortable. It allows for more specific ventilation strategies that come with volume control. So if we have difficult blood gases, if we're just having a hard time trying to get us in an acid-base situation, volume control is easier for that. But then we use pressure control to protect us from barotrauma and volume trauma. And that I time to help aid with recruitment, whatever we may need. PRVC is really good because it improves patient ventilator synchrony, and it's more comfortable for the patient because the patient can determine their own flow. So if they just want a little bit of flow, then they can have it. If they are really air hungry and they need that large amount of flow, then it's more comfortable for them too. It is patient determined. And again, I kind of mentioned this at the beginning of the slide. Different names might be a volume guarantee or VC plus, or if there's different ventilators in different regions I'm not familiar with, they might have it set up differently, have different names for it, but it's the same theory, PRVC. I'm a big fan. It does a lot of good. Here's a picture to kind of help determine, explain it to you guys. So here's our PEEP. Here's a normal tidal volume. So we have our set tidal volume in here. We come up, and this is our measured PIP, and we come back down. Here's our pressure limit up here. And that could be set at, let's say, 30 centimeters of water pressure. If we have a decreased compliance, we're going to need more PIP to get the set tidal volume we want. Sorry, these aren't the same size. Again, I'm not an art major. I'm sorry. So we have decreased compliance, so that lung needs more PIP to accept that set tidal volume. We come on up, and we're limited here. And what might happen is that tidal volume will be less because it's dumping that breath to protect us from those peak pressures. So if a lot of times if you get a low tidal volume alarm, it's because that breath is being pressure limited. And then we come back down. So it stops and comes back down. That's PRVC or volume guarantee that is also being used quite frequently in NICUs. This is just a little chart to remember what gets set where. We have our control modes of ventilation, which is assist control pressure control or assist control volume control. We have a set rate and volume. We set tidal volume, and pressure we set a PIP. Every single one of these you set a PEEP and an FiO2. And pressure you set I time, and volume you set flow. And hybrid modes, it's the same with pressure and volume. So you both set a rate on both of them. And sometimes I'll set, if I have Simv compared to assist control, I set my rate just a little bit lower. If I have a very spontaneously breathing baby, so that they can have a little bit more of that synchrony with the ventilator. But if they're completely apneic, then I can use it as a control mode of ventilation. So we set our tidal volume, we set our PIP, PEEP and FiO2. Both of them will have a pressure support to support those spontaneous breaths, and then I time and flow in relation to pressure and volume. The last, spontaneous modes, depending on if we're in a volume guarantee situation, depends on if we're set a tidal volume or a pressure support. That's why they're both checked. I most commonly have used it as it'll say PSV, pressure support ventilation, but I'll use it as a volume support. Or if you're just straight up using pressure support, you'll set that. So depending on the equipment you're using, and PEEP FiO2. And finally is PRVC. We literally will set everything except for the flow because the patient will determine that themselves on what they want. Okay, ranges. This is the most asked for thing a lot of new respiratory students ask for are, can we please get ranges for ventilation? Let's say, so we'll just go down the list. Rate, 10 to 40 breaths per minute. If I'm just setting a kid up, 20 to 25 is a great place to start. If you're at 40, you're risking air trapping. You're not allowing enough time for exhalation. You can be causing trauma, and that's when you start thinking about maybe moving to a high-frequency form of ventilation if you're at 40 breaths per minute. Tidal volume, PIP or volume guarantee, whichever you're using, we're shooting between 4 to 6 mils per kilogram. And it's not whole numbers. You can use half numbers. I've set kids up on 5.5 mils per kilogram, on 4.5 mils per kilogram. Typically, if you go up, so 4, 4.5, 5, 5.5, 6, is a pretty common practice for increasing and changing tidal volumes. This will be either done with current weight, reference, which would just be their weight for that week. A lot of times you go by the same weight for the week. You calculate this mils per kilogram. Reference weight, which is the estimated weight for situations like, say you have a baby that's very fluid overload, very puffy for whatever reason. We'd use a reference weight to help support these kiddos. And then in the first week, we use their birth weight of life. PEEP between 5 to 12. Typically, if it's just like a term kid that might need some sedation or something, you would keep the PEEP pretty low, between 5 and 7. It's more those chronic lung kids that we go up on their PEEP to the 10, 11, 12 range. Pressure support between 5 and 10 centimeters of water pressure, and then watch your exhale tidal volumes. Make sure that they're within the range of the mils per kilogram that you are intending. I time 0.3 to 0.4 seconds. And that's mostly just as with an adult. I would go off patient comfort in this situation with eye time. FiO2 21 to 100%. Oxygen titration, just I titrate it based off of SpO2. The Pmax, or pressure pop-off, that we talked about with PRVC, I feel like 30 is a good place to start, because if our lung pressure, if our pressures, our measured pressures are getting above 30, there's something we need to address and change. This kid is not doing well. So 30 to 40 centimeters water pressure, depending on what's going on with your baby. Our triggers are 0.3 to 0.4 liters per minute, and that is how much effort the baby has to drop 0.3 liters to initiate a breath. So this is your trigger. And then finally, slope is 0.1 to 0.3, and that has a lot to do with the theory of, it's similar to rise or flow. It's just a little bit different in the fact that it's set in liters per minute, and it's a lot smaller range for neonates. Indications for conventional ventilation would be non-pulmonary conditions, so maternal meds. Maybe mom was given magnesium and this kid is just magged out and is floppy and not doing anything, and she wasn't tolerating pain, and so they give her fentanyl, and this kid just needs to work stuff out, and then we can extubate and it'll be great. It'll be fine. Because we also need functioning mamas. Neurological considerations and cooling. If we just have a kid that maybe took a big hit in utero, or it was not a pretty resuscitation, or whatever reason, maybe there's a congenital issue going on. Neurological considerations where the lungs are fine but the head is not. Post-operative and procedures, so maybe you have a kid that goes and gets a G-tube and comes back sedated. You just have to wait for them to wake up and you can pull a tube. You can provide full ventilatory support if it's indicated. I personally feel like this does better for older kids, and the little itty-bitty prematurity micropreemies don't do better with high frequency. But conventional ventilation can be used for full ventilatory support of bigger kids. Weaning and assessing for extubation. Impending or actual respiratory failure. Acid-base correction, if maybe our CO2 is off, or our breathing is weird because our bicarb is off for whatever metabolic reason, we can use conventional ventilation for acid-base correction. Chronic conditions, as great as high frequency is, you can't go home on it. But if you have a kid that's chronic, they can go home with home conventional ventilators. That is kind of more indicated beyond my experience, I'll be perfectly honest, but conventional ventilators such as the Trilogy are really great for going home. And then extended surfactant administration in more term infants. Sometimes you'll do a neurodevelopmentally appropriate, which just means sedated, surf administration, and then you're like, okay, time to wake up. And we're not waking up. So you might just need to wait for meds to wear off after administering surfactant, or you just need a night to recruit and get some positive pressure ventilation, help those alveoli open up, and we can extubate in a couple hours. It'll be just fine. Okay, now we're going into equipment management. I'm going to focus on the ventilator I'm most comfortable with. I know in all regions and areas they don't use this ventilator, but hey, I'm gonna show you the proper management for this ventilator. It is the Draeger Vita Infinity VN500 ventilator. All right, so we're gonna start with some basics. Make sure your circuits and lines are all attached correctly. Your air's in the air, your oxygen's in the oxygen, your inhalation is where it needs to be, and your exhalation where it's supposed to be. After that, make sure you perform a device check to make sure the ventilator is functioning properly. Before you put it on the patient, the device check can last a while. I don't remember exactly how many days, but you can perform the device check and then turn the ventilator off and put it away till it's ready. But you have to perform the circuit leak test with the proximal flow sensor in line immediately before you attach it to your patient. The reason we do this is it ensures that there's no leaks and that we're giving accurate volumes and pressures to the baby. One thing with the Vita Infinity VN500 is it has a proximal flow sensor, which is great, but also kind of a pain in the ass. So we have to calibrate it once a shift. So you just take it out of line and you tap and get the humidity out, and then you calibrate it off your ventilator. Because it is proximal, humidity and secretions can cause malfunctions. So you have to make sure that that flow sensor stays clean, recalibrated, and if not, feel free to replace it as needed. And that is both the actual flow sensor inline and the cable. Either one of those might need to be replaced. They can be a little bit touchy. So as you can see, here is an endotracheal tube with our Ballard suction catheter and closed suction catheter so that it stays clean and sterile. Here is our proximal flow sensor. Make sure this stays up because it's less likely to malfunction and less likely to get humidity and goo in the flow sensor if you have it up. And it just attaches directly to the Y of the circuit, and then we have our inhalation and exhalation. So this is kind of what the Y of your ventilator will look like. Device circuit check, and then breathing circuit check, and you just press start and it will follow through. Start, okay, and then it will give you the instructions on what to do to make sure it's running properly. This is the screen of the VN500. Down here we have our set settings and our mode we're in. Just take note, just be careful because things are always in different places. Volume guarantee is noted up here. So pressure control, Simv, volume guarantee. So then we go across, we have our FiO2, our tidal volume, our I time, rate, PEEP, pressure support, slope, and Pmax. This is a kid that has a little more chronic lungs, so that's why these are a little bit different than what we would normally set, such as that Pmax of 48. He kind of needs it to live. So down here we have our settings. Right here we have our return volumes and measurements. And different facilities might have different software and different setups, so this is my personal favorite way. Because then I can go across and then I know how much they're breathing while we're doing another I time, FiO2, mean PEEP, because those three work together, our two mandatory and spontaneous tidal volumes, mils per kilogram on our return volumes, spontaneous inspiratory time, minute volume, compliance, whether it be static or dynamic, leak and resistance of the airway. Over here are different options. If you need to change modes for whatever reason, or just anything, and you need to kind of get to the backup menu, you can either click here or start standby and go to ventilator settings. There are also others. There's 3 places you can go to get to your ventilation settings: the ventilator settings button, start standby, or right here. You can change views, specialty maneuvers, things like that. Patient-specific vent data, so you can actually see waveforms. You can see that this is a 3.5 tube. That is a very important part coming up, that you need to make sure that you put in the right size endotracheal tube that is in your baby. PSV screens look a little different, but similar. Just as usual, you have your settings along the bottom, you have your measurements, but the waveforms are a little different because your patient will be spontaneously breathing. I'm a little less I like to analyze what my baby's doing on waveforms in Simv or in some type of control mode or hybrid mode. Spontaneous, I kind of ignore my waveforms because they're gonna be all over the place. So I make sure to check my return volumes and what's going on over here for my baby. Oh, and one thing to note, the most important button, the shut up button, right there. Okay. One thing that's super nice, I'm a huge fan of, is what's called automatic tube compensation. This is a specialty setting on this ventilator, and what it does is you can set the percentage, but it allows the ventilator to get feedback from the endotracheal tube, and that's why we need to make sure it's set. That allows the ventilator to compensate for the resistance of the ET tube. So basically, we have increased resistance from any type of narrowing of airways. What this does is it overcomes it so that all those ventilatory breaths are true, actual breaths of what the baby is doing. Here's where slope comes in. You can adjust the slope to match the ventilator settings to patient effort. And it's not the most technical way, but it works the best way, I found. So again, make sure you have the proper ET tube size in the ventilator. And this will help decrease ventilatory fatigue, decrease workup breathing, that can come from mechanical airway resistance. And of course, a standard Ballard section is compatible with the majority of conventional ventilator circuits. So if you go to your ventilation settings, you have all your modes up here. Then overviews. So here's your trigger, how much your patient needs to trigger a breath. There are others like apnea, ventilation, and sigh. I oftentimes don't set those. Your volume guarantee, so your set tidal volume for PRVC mode. This is called volume guarantee. And here's that automatic tube compensation. See, we have it set at 100% and it's on. It will then form a green line on your waveforms. And literally, I adjust my slope till they match up. I know it's not the most, but it's what I found is the best, has given me the best outcome. If I adjust my slope so that whether I go up or down so it matches those mechanical breaths and those spontaneous breaths, it provides the best ventilator synchrony I've found. So this can be found in your ventilation settings when you're making changes, and then we have general settings, which is where you change your rate, your tidal volume, all that. You can go down to additional settings, and this is where you'll find this information. Looking at your waveforms, you have pressure, flow, and volume. The blue are machine-delivered breaths. The brown are patient spontaneous breaths, if you need to know what you're looking at there. So brown, spontaneous, blue, mechanical. On top of this, I'm going to talk about airway securing and management with conventional ventilation. This is kind of where I'm grouping it in. My side note, different facilities secure differently, but this is my way. And so in my mind, it's the right way. But if you end up in a different NICU, they have their way. Really the biggest thing is as long as your ET tube is secure and you can assess for breakdown and it's properly managed, As long as that tube stays in and is managed, that's the most important thing. But this is my way, so in my brain, this is my right way. ET tube position is important. Like, absolutely vital. The tiniest bit of variability can truly affect your baby. You want to maintain this in a neutral position. If you're questioning and you're not sure and there's any doubt that you're not happy with where your ET tube is, feel free to retape. That's just fine. It is your tube. For that shift you're on, it is your tube, and you manage it how you want to manage it. The circuit, everything's on swivels, so feel free to twist and adjust circuit in order to keep your ET tube in a good position, in a good place. So this is mine. I like to use elasticon tape. I cut it into two pieces of tape, and they're kind of cut like high-waisted skinny jeans, and then a small piece that I use for an OG tube. We use a measuring tape to make sure that our ET tube is in a proper position at the gum line, and then however you decide to prep the skin before you put it down. I like Duoderm for my micro preemies for the first week of life. After that first week, I just use a skin barrier like 3M. Adult term kids, bigger kids, I just use that skin barrier protection from 3M. That's super nice, and also it makes it sticky, so it sticks better too. So it both protects the skin and makes it sticky. It's beautiful. I slather it all over my babies. Well, their face. Okay, so here's our baby that just got intubated. We determined we want this 3.0, you can see 3.0, endotracheal tube at 9. It's kind of hard to see the 9 because it's dark, but 10, 9. So we know, okay, we want this 3.0 at 9. So you will pinch a little bit higher on the endotracheal tube and then anchor your hand on the side of the baby. See how my pinky is anchored? And that's because if for some reason the baby wakes up and turns or moves or somebody knocks your hand, you're still attached to that baby and pinching and holding so that you do not move. Another important thing is proper bevel placement. So we need to make sure that the numbers are down towards the toes. Notice the numbers are down towards the toes and the radiopaque line is to the left. So numbers down, line to the left. And this is so that that bevel, the longest part of that bevel is sitting to the posterior airway, and that the Murphy's eye is positioned so that we can get equal ventilation. After you determine you are in the right position and in the right depth, you prep the skin. You put the first layer down. The top strip under the nose just goes straight across. Make sure you're not covering the nares or anything and it looks nice, straight across. One trick I found is instead of going straight out, if I go a tiny bit curved up, it makes the tube lay a little bit nicer. So curve up towards the top of the ear. After that, this bottom piece right here wraps twice around the ET tube and comes back on itself. So you can see we wrapped it twice around and then taped it on top. After I put that first piece of tape on, I like to measure, do my first initial official measurement. So whether we go from the 11, 10, 9, or the 10, 9, you just have to do some basic math and subtract to make sure that the base of the tape and the gum line is at that 9 centimeters. After that, you take your second piece of tape and place it right on top. This time, the top piece of tape that goes across here, you wrap around once, and then we come back over the top of the lip. Best bit of advice I can give is pinch it while you're wrapping it, and then come across, and don't put it directly on top. See how they're a little bit layered? If you leave it a little bit layered, it's less likely to curl up. Make sure to pinch the tape around the ET tube while securing the second tape. After that, you do one wrap around and across, and then you do 2, and then come back over on itself. And then pinch as you're going to make sure it's nice and secure. After that, I do my second confirmation measurement. So we're at the gum. You can either go off the 11, 10, 9, or the 10 down to the 9. So we are officially secured at a 3/0 tube at 9 centimeters at the gum. That little piece of OG, you can tape the OG to your tube, just don't block where your marker numbers are. And that is part of airway management and making sure your tube is nice. I'm a little bit of a princess and I like my babies to look good, so I'm putting that onto you guys that your babies need to look nice. And that is conventional ventilation. So thank you again to the University of Utah Newborn ICU, Draeger Incorporated for letting me present their ventilator in reference to conventional ventilation, and of course Artie. You can see her freckles real good here. Again, please reach out to me if you guys need anything, whether it's in class, call or text me if you're one of my students, or if you're a new nurse in the ICU, call or text me, or you'll see me at work, or grab me at any point. I'll give you guys my information. I just don't want to give it out here on the internet. So thanks so much, guys. Bye.